ma haaraks kohe kinni täpselt sellest samast küsimustest, mis te ise küsisite viimasena pärast ettekande lõppu, et kas saab ehitada, et kas peaks kasutama süsteemi, mille kasutajad ei ole sellega rahul. Et tegelikult küsimuse peaks tegelikult küsima just nendel põhilistel kasutaja osapooltelt, et lihtsalt kõrvaltvaatajana, mis on uuringutes välja tulnud ja intervjuudes ja küsitlustes on need samad detailid, mis puudutavad info liikumist, patsiendi teadlikkust, retsepti olemasolust, et kas kui kõik liigub nagu kuskil taustal digimaailmas, et kas siis peaks ikkagi midagi ka nagu patsiendile kätte andma, mingisugune paber, et mis nagu toetaks sellist teadlikkust, et umbes nagu pangad, et kunagi üks pank pakkus laenuteenust, mida sul ei ole võimalik näha, aga siis kaasa sai inimene siis sellise torbiku, kus oli paber sees, et ehk siis inimesel tekkis mingi tunne, et ta on ikkagi midagi saanud, midagi käega katsutavat. Aga see nagu annabki nagu kindlust, et selline utreeriv küsimus, et kas patsiendil peaks andma kaasa ka välja prinditud retsepti arsti juures, juhul kui digiretsept on antud võib-olla teistele.
The audience, would you like to give that paper prescription with the digital prescription? Just for the patient.
We always think about the doctor as a drug, and when the doctor speaks with you, that's important. Sometimes when I speak with my nurse afterwards and I've spoken something, and after 10 seconds they have forgotten everything, I just go out of it. And then to give a paper, it's a symbol. Some people, I think, they need the symbol from the doctor or from the institution to the patient, that they keep it in mind in a better way.
But should it be the prescription, or could it be the list of all the medication?
The best is to have both of it.
Arvamusi?
Yes, in the same sense, when I am in front of a patient with a chronic treatment, at the end of the consultation, I print the prescription and I put it under the eyes of the patient and I tell him, do you agree? Is this your medication? And very often the patient is, no, this one, I suppressed it, or it's not good for me, or I take 2 pills and not 3. And I wonder how we can share this with the patient without a print paper between us.
We changed the printed receipt for medication with a receipt for information. So this is the same paper, and there's the link to our website, links to our place where all the patient information leaflets are, and then I write down the disease. And I showed it already to the patient on the screen from what it is. This is the information. For some patients I printed the information, but most patients I give the link with the information to the patient information leaflets and the patient education materials. And all the receipts are going, say, you go to the pharmacy if necessary. But so that's how we solved it.
But who is getting the peace in the heart if you give the paper with you? I have been several times, as you all do, at patients' home finding 7 or 8 different papers with the medication lists. And he or she gives them to me and says, I don't know which is the newest, you choose. So is that the peace for the doctor's heart? Oh, I did everything I could. I even printed it out. Now it's my duty done. Or is it really necessary?
I can answer.
Just
one of our tasks is to make a synthesis of all the prescriptions of the patient to keep it up to date. Say, well, now this is the new prescription with all the the things you have to take, and only the things you have to take, the drugs you have to take.
And Pete wanted to comment.
Well, one of the questions and the comment also is how reliable are your data in your computer? And is your chronic medication list up to date? What we know in our country is that it is not the case. Perhaps maybe e-prescribing can enhance the quality of that, but are there any, is there anything known already about this? Is the quality of the medical records and the medication in the medical record better with e-prescribing or not?
And we started the discussion with going forward, but I think we're going back.
Yes, well, I kind of rephrase it a bit in a misleading way. The question was more about patient education after receiving the drug. A paper or a mobile app or looking up the medication list on the internet are the possible technical solutions. But yeah, just thinking of the people who don't have access to smartphone or internet to check up the medication list, which is possible right now in Estonia. This was the kind of the question, but all in all, like patient education, what should be done? Should there be any mobile apps, and what should be done, for example, in the pharmacy also regarding the consulting the patient how to administer the drug and how to avoid the adverse drug effects.
Thank you. Erki, you are the father of Estonian digi-prescription. So your vision, where should it go? You guide your child.
Regarding this matter we just discussed.
Yeah, or other, yeah.
For me it also seemed like, remind me the early days of launching the prescription here. We had the same issues, but at least for Estonian doctors I think this is not such a big issue as you just described. So they just have found a way to run it smooth, and don't think it's a big problem. But if to look at the future prospects, then I think we should clearly separate two things. One is the central database, which we at the Estonian Health Insurance Fund are responsible for, and the other is the applications around the audience in the pharmacist offices and the doctor's offices. And I think that even the central database is not ready yet. And we have discussed it in a health insurance fund that several things still need to be looked at. For example, we'd like not to run into same trouble as the patient health record is currently in Estonian, that it contains lots of data, but it's all in a narrative way described here, so it's not usable. I think we are doing much better in prescription area. Something like perhaps 90% is pure data, which can be used, but still there are some fields of data which are narrative. For example, the administration part, right? Some other parts too, but we should also think how to make it also fully data thing. This would enable to move further. For example, if we have this administration part also, the data-based description, then we will have the possibility to monitor the patient's drug adherence more precisely, because currently we know that he's using, he was prescribed a pack of tablets, let's say 60 tablets, but we can't really tell when should patient come back for a new repeat prescription, because we don't know how often he or she would have to administer those tablets. If we know that, then we can automatically get the new information and perhaps have the more active way in managing the patient. So So this is one thing we will definitely look in the future. There are some other things too, a couple of times mentioned already, that we should perhaps look, is it possible to integrate the data about medicines which are used in hospitals, because these are serious medicines too, and they also may have an effect, and also perhaps in some way the OTC medicines can be integrated, although I think this is a much more complicated way. So from the perspective of central database, this is how we'd like to move further.
I've got a stupid idea about sorry, yes. Christina, you're welcome.
In Denmark we have prescriptions from the specialists in the hospital, and prescriptions from the GPs goes in the same system, which is national and it is updated. Whenever one prescribe in the system, they need to push a button which then goes centrally into the database, and there's a date which state that now the medicine card, we call it, is updated, which means when the patient comes into the GP, ideally, I say it like that because it's a new system in Denmark, and I mean it's only 60-70% of the GPs that are actually using it right now, but upcoming, hopefully. So the chronic medicine is always updated.
Can I ask a quick question back to you? I think Erkki was meaning the in-hospital use.
Yeah, but the in-hospital use, the thing in Denmark, or the meaning, I think, is that the medicine card should be the drugs used by the patient in everyday life. So in-hospital drugs, which are not given at home, will not be shown in the medicine card, because that is not something the patient is taking. And then the third thing is, I have a wish in Denmark that we could have a solution where the patients also can get into the medicine card on their own medicine card, of course, with security and everything okay, and then to check some boxes that this medicine I use, no, this medicine I don't use anymore, and then before consultation, and then coming into the doctor and having a discussion on the medication, we as doctors would see before them, then they would have shown us what they actually take of the medication, because I think there's a big discrepancy between what they actually take and what we prescribe.
Any comments? Christina, what do you mean by prescription was updated? So the new prescription done for patient, do you mean that? Or checked by nurse or doctor, or a patient reminder on that? Or both, or all?
It's only the doctors that can check in the medicine card. And when I prescribe a new medication, I put it in the medicine card, and I check that all the medications in the medicine card is, I check with the patient. I ask the patient, do you take all these drugs? And he said, yes, I do. And then I check the list. So when the patient sees another specialist, the specialist will know, okay, the patient, I can see by the date, this is 10 days ago, did you change your medication? No, I didn't. Well, okay, then I can check the box once more. So every time the patient sees a doctor anywhere in Denmark, the box will be checked. But my wish is that the patient also can go in and check the list, so that I, as a doctor, can see, okay, the patient doesn't take this kind of medication anymore. Not that they can change the medicine card, but just have another box so I can see, okay, this turns yellow, that's because the patient actually doesn't take this medication, and then we can have a talk, why don't you take this?
Only a short comment. the most problems we have with the older people with a lot of medication, and these people are those who have difficulties with all these techniques. The young people or the people like we are, then don't take so many medications and the problems are not so much. But when you get 70, 80, 90 and you get a lot of medication and then you can't work with these technical support.
Is there any countries who use their patient reminders to the telephone, for example, if the medication runs out? Because the telephone is used even in 90-year-old patients already. So I think this is the easiest way, maybe, but costly. Yeah. Just.
May I comment on the topic of compliance to medication? Because I see there's a large expectation from a database and showing results that patients are not compliant. But I think we know a lot of patients are not compliant. And I think, do you know any literature that only feedback on compliance is effective in changing the behavior? I think that's the problem. So we know it. I think we are starting a program that we start from the beginning, that in the first prescription of a medication, a chronic medication, we try to make a psychological and practical profile of the patients and to assess barriers for adherence, like doctors. They don't trust doctors, they don't trust medicine, they are afraid of side effects, or they have practical problems, or they forget. And then the intervention should be focused on what the profile then is. So I think that's maybe a way of trying to get therapy adherence better. And I don't expect so much from data, so that's just a remark.
Britt, would you like to comment on compliance and?
Jah, ma jätkan eesti keeles, pool auditooriumist on eesti keelt rääkinud ja ma saan hakkama inglise keeles ka, aga et teistel ei ole neid translaatorit ei olemas. Et ma arvan, et sellel edasiarendustel võib-olla tõepoolest on ka selle ravimsoostumuse osas palju ära teha, aga seesama, mis on nagu siin korra läbi käinud, et seesama meenutussüsteem, et ravimid hakkavad otsa saama või et teine asi, ravimsoostumist kindlasti mõjutab hästi palju see, kui kõiksugused koos ja kõrvaltoimed on arvesse võetud ja patsient on hästi teadlik nendest, ehk et see teavitamise ja nõustamise pool on hästi tugevasti ka, miks mitte toetatud erinevate nende tugede poolt, ehk et patsiendile välja prinditavad võib-olla sellised informatsioonimaterjalid, aga teisalt ikkagi seesama arst on kaalunud hästi hoolikalt läbi selle kõik, eriti just eakamate inimeste puhul, kellel 5 rohkema ravimi kasutus ei ole mitte haruldus, ehk et on kaalunud väga põhjalikult läbi otstarbekuse, eks ju, kõrvaltoimete profiilid ja koostoimed ja see ongi nagu minu visiooni, minu nägemuse edasine nagu selline arendamise viis, et kus digiretsepti üksinda ei arendada edasi, vaid ta ongi nagu just nimelt üks osa, eks ju, terviklahendusest, e-tervise süsteemist, ehk et kus kaasatakse retsepti või ravimi otsustamisse kõiki patsiendi olemasolevaid terviseandmeid, kaasa arvatud erinevad haigused, eks ju, tema kliinilised näitajad ja siis sinna juurde veel need kliinilised ravijuhised, et millal oleks otstarbekas kaalu, et kas see ravim on kaalub üles, eks ju, võib-olla need kõrvaltoimed tegeliku selle positiivse toime ja nii edasi, et ehk et see kõik on nagu hästi kaalutud ja ma arvan, et see on ühe ravimsoostumise alus, ehk et teadlik otsus, kaalutlus sinna juurde ja siis ka meeldetuletamissüsteem ja kontrollimine.
Kommentaari, palun.
I have a short comment about, well, we talked about whether to print out the prescription or to give an overview of all of the prescriptions. I think the cornerstone here also is patient education to improve adherence and treatment outcomes. So about 2 weeks ago, I was given an assignment to give a lecture to the open environment, to all the people who would want to come. So I had a group of elderly people taking a lot of medications, and I was actually telling them about the most important idea that you should know your medications. Just to say that I'm taking this one white pill is not enough. It's not enough in the dentist's office or in the pharmacy or when you go to another doctor. So you should know your medications. So I think the digital prescription, in a way, pushes the patients to know more about their medications. Because in the older times, they took their paper prescriptions and maybe saw that the name of the medication was the same that they needed, and they just went to the pharmacy and asked for a new refill. But now they actually should know why I'm using this or that prescription. So in a way, it's complicated for the elderly people to know what kind of prescriptions they have, but it pushes them more to know what kind of medications they have.
Any comments?
No, võib-olla nii-öelda arsti vaatena ütlen, et ma ei ole alati kindel selles, praegu vähemasti, võib-olla kunagi tulevikus see nii on. Aga et täna ma näen pigem segadust rohkem selles, mida ei tingi ainult see, et on digitaalne väljakirjutamise süsteem, vaid selle digitaalse väljakirjutamisega seoses on seesama geneerilise nagu nimetuse järgi ravimi väljakirjutamine. Ja täna ma näen, et just nendel, kellel on palju ravimeid, eakamatel inimestel palju haiguseid, ma siiski pean andma neile kaasa just nimelt selle informatsioonilehe, selgitamaks ka seda, mida mingi ravim tähendab, mille pärast ta seda võtab ja et nende geneeriliste toimenete taga või nende need toimed on ühe taga, et nad on saanud aeg-ajalt ka erinevate nimetustega ravimeid, et need on samad asjad, et nad ei võtaks neid topelt, ehk et siin on praegu küll ei ole ma alati väga kindel selles, et see kõik on nende teadlikkust palju enam tõstnud, aga teadlikkust saab tõsta just nimelt sellega, et või seda ohutust ka, et me ise ka veel anname informatsiooni kaasa ja seletame üle ja tšekime kõik alati üle, et see on nagu see.
Aitäh! Diana Ingerainen, Eesti Perearstide Seltsi juht. Et minul tekib selles mõttes küsimus, et kindlasti on arstil oma roll, patsiendil oma roll ja kas me nagu ei ole võtnud arstidena nagu liigset vastutust nende ravimite osas, et minu patsiendid tihtipeale tulevad, teie teate, vaadake kompuutrist järgi, millal mul peab üldse midagi olema. Ja võib-olla, et meil on jäänud nagu see patsiendi rolli või tema vastutuse selgitamine kuhugi kinni või kuhugi ära. Et minu arust see digiretsepti edasine areng, kindlasti peaks olema üks vaade arstil, apteekril, patsiendil ja selles patsiendi vaates peab olema ka, ütleme, selle haiguse, tavaliselt siis kroonilise haiguse kulu nagu osas selle sama nagu patsiendi rolli või vastutuse selgitus. Et siis me saame nagu selle meeskonnatöö arst-patsient on paremini kätte.
Ma ei saa sinu käest küsida, kuidas?
Ma arvan, et kui me alustame sellest, et me selgitame, mis on selle haiguse olemus, miks me seda ravimit tõepoolest välja kirjutame ja tegelikult mis on selle mõte, kui me kirjutame ravimit välja, et seda tarvitatakse pidevalt, aga mis me siin Eestis nagu näeme, et tihtipeale see ei ole see pidev tarvitus ja siis tekib ka rahastaja poolt küsimus, et mis ma siis seda ebaefektiivset ravi siis üldse rahastan, et kui see tegelikkuses viib ikkagi tüsistusteni. Et siis kokku minu arust esimene samm on see selgitus, mis on see haigus, miks see ravim on ja see vastutus. Täpselt nagu Rutt näitas nende skeemide puhul, et kui ma teen nii ja nii, siis minu risk langeb. Täpselt samamoodi peaks olema kõikide nende krooniliste haiguste juures, et kui ma seda ravimit võtan, mis on siis minu variandid ja kui ma ei võta, mis siis kõik juhtub.
Et selles mõttes ma oleks nagu väga nõus. Et eile me vaatasime Ivos meelega veel edasi ka just seda patsiendi infot, mis on, et põhimõtteliselt me peaks iga kroonilise haige puhul panema käima vastava makilindi, eks ole. Et seda ei ole ju mõtet nagu sadu ja tuhandeid kordi läbi sadade ja tuhandete arstisuude ja õdede suude nagu teha, et Hollandil on olemas täiesti geniaalne andmebaas selle kohta, et ta ütleb ainult lause, palun minge sinna leheküljele ja vaadake ise. Pluss veel seal olid olemas täiesti geniaalsed patsiendi otsustustoed, mis võtsid arvesse ka patsiendi isiklikke uskumusi, talle räägitud kuulujutte, selle haiguse kohta müüte, et see on kindlasti nagu ka nagu meie unistus, kus suunal nagu võiks tegelikult edasi minna.
No just, et nii nagu me oleme siin Eestis ka nüüd ju püüdnud, et kui meil on ravijuhised, siis meil on ka patsiendijuhis ja minu arust kõik see peaks olema vähemasti e-riigis digitaalne ja nüüd klõpsti kättesaadav, et õnneks on Eestis olemas patsiendiportaal, mille saamiseks on väga palju nagu kulutatud ja välja mõeldud ja sinna ma arvan, et järgmisena tulebki see osakond teha, et on üks vaade oma ravimitest tõepoolest, et see laetakse selle arsti poolt uuesti üles, kes uue ravimi kirjutab ja vaadatakse kogu aeg üle, aga põhimõtteliselt, et see vaade tekiks kõikidele osapoolidele.
Ja need, kes on nagu konservatiivsema tiiva esindajad, et saaks ka vajutada print-nuppule ja selleks võib olla nii patsient ise, arst, õde, patsiendi lähedased, et kõik ei pea olema sul kogu aeg raputatava äpiga.
Ivo, can you give a comment about this?
Yeah. What we have a kind of system we call doctor at home, and that is predominantly we say a doctor at home because it's information before consultation, during consultation, and after consultation. And we tried that every GP uses that website. It's used about 70,000 to 80,000 times a day. And in the website, from all the diseases in general practice, there's patient information. We make the patient information with a group of patients. And it's not only about chronic diseases, but it's also about sore throat or itchy ears or something like that. And you can assess it by two ways, by text or by the body, and you click and you go further. And now we are incorporating decision aids in it. So from several diseases we have already decision aid. I showed you yesterday even about tonsillectomy. And we have from prostate, from radicular syndrome, all those things have decisions aids incorporated so a patient can make their choices themselves. And so we are now developing option grids so that we are including option grids in it. So we have two choices, what are the advantages, disadvantages, chances. And then in your surgery room you can use it. And you can give the link to the patient or print it in certain patients. You have to make it tailor-made so patients can go further with that information after the consultation. And I think one of the reasons for the success is that it is one-to-one to all our guidelines. So if the guideline is made or updated, at that moment the patient information's situations, we call situations, per guideline about 6 or 7, they are updated also, or they are in a new guideline, we have new situations. And there's only one website patients have to go to. And that's also important in adherence to websites. And sometimes we link to then further information, patients, organizations, websites, and all those things. But that's the way it works.
I think that's only part of the solution. I think we will not resolve it only with IT and with patient information, things like that. I think what we should also rethink is within the doctor-patient's relationship that we emphasize far more patient participation during the consultation, the first step, and especially in chronic diseases, even patient empowerment, which means it's not me as a doctor who's deciding what you will do, or taking medication, or going on a diet, or things like that. It's you, and I will coach you to take your responsibility for your own disease. And I will negotiate with you which are the things you can do within your context. And I think this is something we have to teach in colleges and to teach to doctors to emphasize more on that, especially for chronic diseases and multimodalities.
Ruth, you wanted to comment?
I just wanted to ask, or to make not a comment, but to ask, or to comment first. I think that this is future in Estonia too you described in Netherlands. But my question is about how What is the amount of the population who uses this internet in Netherlands?
And the age groups.
And the age groups, because I know the last population study in Estonia showed that there is only 1/3 of the population over the 65 who uses the internet. So it's only part of the solution, or only for some of the people, not all. Yes.
I don't have real data. We are exploring that, but you're right. So I also give it on the print, and I also give the link. I hope some family member will find it, the daughter or the son will look it up, the information. But it's only a part of the story. I think e-health and all these solutions are small parts of building up, and we have to use the patient profile. What is best suited for this patient? We are now working on research to make a patient profile in chronic patients. What is his activity capacity? What is his health literacy? What is his computer literacy? And we have to have, are there fears? Is he depressed? So, and then if you have that profile, you first have to talk about that profile and give your interventions based on that profile.
Yes.
And we researched it, and it didn't work yet, but we have to go further in it.
Üks väike kommentaar siin nahkul on, et Ameerikas on tehtud uuringuid selle kohta, View Internet, umbes 50% tervisepäringutest internetist tehakse kellegi teise nime. Nii et see vanuserühmade puhul peab silmas pidama seda, et kas tehakse otsingud enda jaoks või siis kellegi teise jaoks.
Aga ma tahtsin minna korra sinna teise poole peale siiski ka. Ja mis puudutab just neid andmete kogumist, tegelikult meil on tohutu hulk hästi struktureeritud andmeid, väga detailseid andmeid. Et ma puudutaks just seda kvaliteedi analüüsi, kvaliteedi parandamise vaadet, et kas teil ei ole sellist tunnet, et me natukene alakasutame seda võimalust? Et äkki ma tahaks seda küsimust küsida Alarilt, keda me kutsusime ka siia konverentsile tegelikult alguses esinema. Ta ütles natuke kurvalt, et ta esinema ei tahaks tulla, aga diskussioonis osaleks. Mis sa arvad sellest?
Ma ei tahtnud esinema tulla, ma mõtlesin, et ma olen äkki liiga kriitiline. I asked the organizers if it's a discussion about how to improve the world or how to improve the Estonian system, so I'm kind of divided. I think you're right about the Estonian system, that the mercantile aspect of it works extremely well. But in many countries where, we wouldn't mind to live in, actually the development of the prescribing has started from the pharmacotherapy point of view. And does the prescription afterwards get to the pharmacy on paper or via wires? It doesn't really matter much. The e-prescribing is rather a tool around the decision aids and the information. We have the opportunity to have both, but we currently have a very good mercantile thing with a huge amount of data that doesn't come out of the database anymore. I have good experience of trying to get pieces of it out to be analyzed, and it's not a very easy system to give anything back, put everything in, but it's rather difficult to get the data out again. So I'm sure you're right that we don't use it, and that there are probably two levels. One is to have snapshots and research interest now and then there is the regular feedback and what you would consider regular feedback. Well, the adherence issue certainly was one. I agree that it doesn't really matter how much drug boxes the patient carries home. We don't know how much of them will be taken, but it at least indicates you were a subset of patients who don't even renew the prescription, so you know there's a problem. It cannot be adherence, but that's only part of it. And what we don't have, but I think is extremely good, is the general patient medication card. And we can have it in a roundabout and very uncomfortable way currently, looking at all the prescriptions and trying to think that is there still a pill or two at home. But I think the renewed each time thing is a very good thing. But we don't have a decision tool on drug interactions. which must be a very easy thing to do. And I think it's partially because we have developed this central database on a kind of country level, and we have left all these functional tools to private developers. And I think it's a very bad thing that has happened with the specialized care and with the hospital systems, where everybody has their own hospital database, and that's torpedoing the general collection of data. It's a little bit better with prescriptions because we still have a standardized set of data, but I have a strong feeling that we will never have these tools, feedback or decision tools, if we don't develop them on a national basis.
Okay, but when you think out of the box, if we don't have those borders that we never can't have, what would you like to have? What can we do with this? All those data,
I would like the GPs to have a. If you push things on GPs, you make GPs unhappy usually. Look at what you're doing. So it might be a good thing to have something that you can kind of pick yourself what type of feedback you would like to receive from the system. A few of the indicators around that. And then I honestly believe that we should have some of the decision tools around interactions and warnings around the kidney function or whatever built into the system. I don't think we need an awful lot, but I would like the idea that you go and ask the system and it gives you answers, comparison with your colleagues or whatever, but not so sure that the system should push it to everybody, because then you ignore it, I believe.
I must say we have kind of used to it, that every development brings an awful lot of noise, but the caravan has to go further. So, any comments?
Mina olen Andre Vetka ja olen apteeker. Võib-olla ma võtaks selle küsimusest kinni, et mida mina nagu apteekrina, kui nüüd unistada edasi, et mida mina ise näeksin, millest võiks kasu olla, siis digiretseptikeskus tervikuna on muidugi fantastiline asi, et enam ei kujuta ette, et mismoodi oli võimalik enne seda töötada, et see tundub täiesti imelik, et maailm võib nii kiiresti nagu muutuda või see töö võib nii kiiresti muutuda. Ma arvan, kõige rohkem muutuski nagu selle apteekri töö seoses digiretseptiga. Aga üks asi, mis tõesti nagu tunneks täna vajadust igapäevatöös on mitte ainult e-retsept, vaid tegelikult ka e-raviskeem. Et see oligi see, mis tuli Hollandi ettekandest välja, et mis neil nagu väga hästi on programmis olemas. Nad näevad väga hästi seda tegelikult reaalset raviskeemi. Millised ravimid, eriti just kroonilised ravimid on patsiendil välja kirjutatud. Ja täna apteegi vaates on hästi palju erinevaid retsepte, mille mõned on kirjutanud haiglaarst välja, mõned on kirjutanud perearst välja, osaliselt on kattuvad, vahepeal on raviskeem muutunud, aga retseptid ikkagi jäävad sinna kehtima ja tegelikult ei olegi head kohta, kust järgi vaadata, mis on see tegelikult see viimane raviskeemi otsus. Ja kui selline asi tekiks, mis oleks tegelikult võimalik kasutada või näha kõikidel spetsialistidel, kõikidel arstidel ja kõikidel apteekritel, et siis selle pealt oleks minu arvates nagu päris palju võimalik parandada kvaliteeti ja just seda ravisoostumust, et sinna juurde saaks tegelikult ka linkida kogu selle ravi jälgimisega seotud aspektid, et näiteks, et kui vastavalt selle raviskeemile tegelikult kuna on viimati ostetud välja erinevaid ravimeid, mis on konkreetsed preparaadid ja nii edasi, et seal on väga palju erinevaid kasutusvõimalusi. Just võib-olla küsikski perearstide nagu arvamus sellest, kuidas tundub nagu see variant, ja seal just modifitseerida, et teil endale ka tuleks sinna nagu väga hästi nagu ülevaade, mis on haiglas kirjutatud ja nii edasi.
Absoluutselt, et me oleme kahe käega selle pool, et eriti kui see ei puuduta enam seda, et üks ravi lõpeb, teine algab või need karjutakse kõik korraga, aga kui meil näiteks tekib vajadus preparaati vahetada, sest et minu kõige koledam ilmselt ma ei ole veel kõiki koletusi näinud, aga üks selliseid vastikumaid kokkupuuteid esmatasandil oli see, et kui meie mõne sattus patsient, kellel oli kirjutatud statiini, siis oli keegi teine doktor vahetanud selle teise statiini kohta, aga patsiendile info andmine oli puudulik, mis lõppes sellega, et patsient võttis need mõlemad korraga ja arvas, et ta ravib omal diabeeti. Et selliste situatsioonide kordamist tahaks kindlasti vältida. Ja see oleks raviskeemi olemasolu oleks kindlasti üks variant, kuidas see võigiski juhtuda.
Ma tahaks paluda Tanelilt kommentaari enne, et sellise, ma tean, et e-tervisega on mingil moel ravimilehest teema kerkinud, ma ei ole detailidega kursis. Kuidas selle teema kommentaar Haigekassa poolt on, kas niisugune asi on võimalik lähitulevikus või üldse mitte?
Perhaps on this particular issue, Erki, you want to add, but I would just like to really to emphasize 2 points. Well, first is about the Estonians' e-health data that you already referred to, that is in abundance out there. That is true. Of course, our problem is that we have essentially 2 big sets of data. One are e-health data, which is in the central database maintained by the government essentially. The other set of data is with Estonian Health Insurance Fund, which are the e-prescriptions, and also what is very important source of information are e-invoices. Of course, the problem is that, as Diana pointed out, that if we at one point in time have such a patient gateway or patient portal that includes absolutely everything, including patient guidelines or whatever there are, to that end you need to use the both sets of data actually from the government's database and also from our database. This actually what is lacking. This coordination is simply lacking. Now I would like just to point out what Anna you said, that you didn't comment, but we obviously can develop with in health insurance fund certain public goods, if I put it that way, like this interaction thing. We can make it easier to access our data. Although I would say that already now the question is more on a technical level, how to provide all the feedback, everything like that. But what are really we're missing in Estonia is, as you said, a central body. I really think that the health insurance fund cannot be the one who will be the sole responsible for developing all these issues, all these things. We need a more, should I say, a stronger role, either the ministry or of the National Health Insurance Institute, I don't know, but someone who should really own the process. I mean, it can't be health insurance fund only. This is absolutely clear.
If you find a capable person, always try to add one more.
Yes, that's
that's why everyone is looking at you, because the few things that tend to work in Estonia, the public goods in healthcare, they are developed by the health insurance fund. So I understand your dilemma.
But I just, I mean, this discussion is becoming probably a bit too centered on this small country. But the fact is that while this smallness has certain advantages, the smallness has also disadvantages, and these disadvantages sometimes show up in a various ways that actually in Estonia have resulted in a situation whereas we are a bit lacking stronger coordinating role of either a government or then the government affiliation of National Health Institute, for instance, that would really own this process a bit more than we can do from our part. But that's
rohkem kodumaiseks tarbimiseks, siis ma räägin eesti keeles, mul on ka siin natukene raske siin diskussioonis osaleda, sellepärast et kohe jookseme samasse probleemi, et tegelikult tahame kogu maailma ära parandada ja diskussioon ometi pidi keskenduma digiretseptile. Et siis ma natukene tahaksin informeerida, et tagasi vaadates võib-olla tõesti kuni tänase hetkeni on läinud suurem osa auru sellele, kuidas süsteemi üles ehitada, algne andmebaas ja me pole niivõrd kiiresti suutnud mõelda, mida sinna veel võiks juurde panna, siis tegelikult nüüd umbes aasta aega me oleme vaikselt ise ka mõtelnud, et hästi palju ideid tuleb. Me oleme niimoodi enam-vähem kokku haigekassa sees, et me tellime ühe sellise uuringu võib-olla, kes vaatab natuke lähemalt, mida soovitakse, mida kõige rohkem oodatakse, võtame sellise koordineerituma lähemuse asjale. Siis Alar tõi välja selle küsimuse, et andmeid on raske kätte saada, siis osalt on see kindlasti õigus, kuigi sa vist oled enamuse asju sa saanud, mis sa oled tahtnud. Hiljuti pangetäie miljonite kaupa retsepte, ma mäletan, oma uurimistööks, mille tulemused kindlasti on väga huvitavad. Aga jah, need andmed saavad olema lihtsamini kättesaadavad ja selleks on tegelikult algamas ka konkreetne riiklik projekt, mis täpselt ma ei tea selle detaile, aga meil on plaan maksimaalselt suur hulk andmeid teha nii-öelda avalikult kasutatavaks, nii nagu näiteks on Eesti Statistikaameti praegu kodulehelt ise võimalik valida, millist aruannet soovitakse koostada. Ma ennustan ette, et see on päris pikk projekt saab olema, aga vähemalt me oleme ka sinna poole liikuma. Teine asi on see, et millist tagasisidet on võimalik retsepti andmebaasi pealt saada ja seal ma ka ütleks, et see saab tulla ikkagi ainult arstide poolt see initsiatiiv. Ja tegelikult väikeseid tükke me juba oleme ka teinud, on üksikuid aruanded, mis puudutab hüpertensiooni ravimite kasutamist, on meil diabeedi kohta midagi, eks ole, ja siiamaani on lähenemine kokkuleppega selline, et alati, kui meil valmib uus ravijuhend, et siis me vaatame läbi, kas sellest ravijuhendist tuleb soovitusi, mida siis saab selliseks aruandeks komplekteerida ja hakata perearstidele tagasi saatma. Tõsi, need aruanded praegu on kättesaadaval sellisel kujul, mida ei ole mugav kasutada. Teanamist on kasutanud need läbi selle ISPi ja siin on minu meelest koostöö koht nende tarkvara arendajatega, kes peaksid mõtlema, kuidas ta teha nii-öelda, kuidas see valada perearsti töölaual sellisel kujul, et ta on lihtsasti kasutatav. Nii et siin saab olla ainult koostöös tee edasi.
So just indeed, I fully agree that we really need to somehow try to define what is our role to develop a public good that everyone can use, or then what is our role just to make the data available so that either essentially that the private sector can develop applications or whatever to access the data and then to make it usable for end users. We simply have not enough. I mean, we cannot do this only by ourselves.
Yes, I want to comment because we have a lot of expertise in developing feedback in Belgium out of insurance and invoicing data. There are some pitfalls and you have to take care of that. One of the important pitfalls is the data, just as they are, they give no information. You have to move from data to indicators. And to do this, you certainly have to have the doctors with you. If you not ask the doctors which are the indicators which are interesting for you, you will give feedback which they will say, we have no message with it and keep it, we are not interested in it, and you will undermine further feedback. They will not be interested in feedback, it's nothing for us. On the other hand, if it is interesting for them, if they are really participating in the development of the right indicators, then it's very useful to get better quality and to give good feedback. But you have to think very cautiously how you will develop the indicators, who will participate, and make sure that they are acceptable indicators for the doctors and not something out of control, but something to enhance quality, to make sure that the quality gets better.
And I must say, we have made a very nice beginning in cooperation of Insurance Fund and Estonian Society of Family Doctors, and we have already integrated some medication indicators to our quality system as well.
I would add to Pete, it's also important who is presenting the feedback. Is it your peer? We have good experience in Denmark with it's your peer that's coming and giving you the feedback. It should not be somebody or something outside. Somebody who knows your world and respects and can feel why do you make the choices you make. So it's the right feedback and given in the right person in the right surroundings. We've talked in Equip about, for example, quality circles, when you discuss your own way of working with your colleagues, and then in a secure and way when you can admit your faults or your lacking of knowledge, or why you do like you do, and that's the way to move forward.
May I add one more comment on your? I think cooperation is very important, but if patients are your customers, I think and safety and quality is an issue for the patient. I think you have an important role in stimulating that. I think that you have a role in stimulating that in cooperation with the doctors and the nurses and the pharmacists. But there's the issue of the funding of those projects. So together, but for the money, I would call you. I'm sorry, I heard you were a banker before.
I think that our e-prescription system currently at least has some technical tools to support us, that peer review, so you can compare what you are doing with the other doctors, and then as Larry referred to, then we have this formal quality system that we can discuss, that we look at between health insurance fund and the society of America.
So, I have to finish this interesting conversation, and we prepared the other question also, and the question was, you can show it, the question was, is the over-European digi-prescription possible? Do you find it possible? I think we leave it in the air, because otherwise we will meet in the breakfast. Any comments? Yes.
Jaa, see on võib-olla selline moorikas, aga ma ikkagi ütlen selle ära, kuigi ma tean, et seda võib-olla paljud tahaksid öelda, aga meil on ju e-volinik Euroopas. Seega ma arvan, et me teeme selle ära. Aga tulles nagu nalja juures tagasi tõsiseks, et siin on palju tegemist ja ühtseid regulatsioone ja standardiseerimist ja selles mõttes ta võib olla kusagil kaugel tulevikus, aga ilmselgelt see, ma ei tea, aga vajalikkuse osas ma tunnetasin ise sel aastal, kui ma käisin rahvusvahelisel konverentsil ja jäin järsku teisel päeval haigeks. Ja nii haigeks, et mul oleks vaja olnud antibiootikumi retsepti. Loomulikult seal oli ümberringi palju perearste kohalikke, kelle käest küsida. Aga nii hea oleks olnud, kui ma oleks saanud helistada oma perearstile ja saada apteegist siis digiretsepti. Nii et ehk, et see vajalikkus nagu ilmselt on olemas.
Aitäh kõigile. Thank you for being here.
Korra veel ütleks